And we are live.
All right, welcome back. This is Senate Health and Welfare. We're looking at H414, a bill regarding an unused drug repository for Vermont. And we have with us Representative Goldman. Why don't you introduce yourself and give us a quick overview of the bill?
Yeah, thank you for having me. I'm Representative Leslie Goldberg from House Healthcare. One of our witnesses described H414 as warm and fuzzy, and that was really a nice image for this bill because we deal with so many things that aren't that. This bill allows the Department of Health, Vermont Department of Health, to create rules for an unused drug repository program. And the idea is those programs collect, inspect, and redistribute prescription medication to those that need them. And the program helps Vermonters access critical medication, reduce environmental contamination of unused drugs, and also reduce system cost. The way it's set up now is that hospitals and long-term care facilities are responsible for disposing unused drugs. They frequently get incinerated or go into landfills, so they get into our streams. And to be able to recapture them in a safe way and redistribute them in a safe way would do that environmental protection and reduce costs to those entities for having to dispose of them. And it will help individuals get drugs at no cost. So this whole program would not have any cost to any of those players. The proposal and the rules have to be established, and that's all that this bill does. There's no money attached to this bill. The idea is that once the rules are established, perhaps in the BAA, it could be funded. And then once the rules are established, then the costs can also be determined. So it's unknown at this point. In our committee, it was voted out 9-0-1. This committee, back in 18, I think, asked for a study on this topic, and it was reviewed again in 2022. And in the 2022 version, there's a quote that, if I may quote from that, as in 2018, it remains clear consensus that Vermont should participate in an unused drug repository program because of the significant health, economic, and environmental benefits anticipated in such a program. So there is a section involving insurance that's going to protect anyone in the program. It will be, there are organizations, nonprofits that manage these programs. And in Iowa, there's a lot of history there that manages these programs. So it looks like it could be a really good thing for Vermont. There are like 40 states already doing it.
Oh, so the last of the
European.
I know, I remember looking at Iowa's program, it's so robust.
Yeah.
It's amazing.
Yeah. Very interesting.
Well, this is good.
Yeah, so the report also notes it's the organization that does it is called SafeNet RX. It's a nonprofit charitable pharmacy, and they found in Iowa that for every $1 invested, they got $8 worth of medication donated and redistributed.
Wow.
So it's quite a savings there.
Wow.
And they estimate when they looked at the report that maybe in Vermont it would be between $3.5 to $7 million of savings.
How much was that?
$3.5 to $7 million annual
That's a bit of a
potential.
range, but it's still.
Yeah, it's a
significant
range, but
either way.
yeah. So it depends on the rules. It depends who participates. So that's yet to be determined.
Ooh, Questions committee. Okay.
Safeguards.
SafeNet RX mean that?
Well, how do we safeguard?
Oh,
make
that's a
sure that
really important
Somebody
question.
doesn't have any contamination from opioids.
Yeah.
I worry about that going to the pharmacy now.
For sure.
Really, how do you
Really
know the
important
source?
question, yeah. The rules are gonna determine the process. It's likely opioids won't be involved at all. And in these nonprofit organizations, we can determine that. So likely if the rules say no opioids, that would take care of that problem. And then the processes of the safety going from long-term care facilities, hospitals, and then redistributing is done by an organization that has expertise.
So it will be rules, yeah.
Big
Senator
rules.
Weeks is gonna keep an eye on.
So are there gonna be like, is this the spectrometers that you talked about? for
Oh,
the-
the testing piece,
testing
we can
piece?
we'll ask Department of Health
Okay.
about how that might play out.
Mhm.
Go ahead.
So currently there's the mail-in program for unused prescriptions and over-the-counter drugs in Vermont, correct?
I'm not familiar with that.
Oh, great program.
Right.
What do you, I'd love, maybe
So-
clarify.
I think it's Department of Health. You request a mailer, you put in your unused prescription, or,
Oh, I see.
yeah,
Mhm.
and you mail it back.
Disposal program.
Okay, but I believe it's all incinerated. So the change here is Vermont sets up their own program, because I believe they get mailed out of state, but.
And
Vermont sets up-
incinerated.
And then the other significant bit is that there's a potential to reuse some of the drugs. That's kind of the major driver in this. Is that
Yeah, and the newest report said that individuals might be able to be involved, and that would be taken care of in the rules as well.
Oh, individuals. So this is more about institutions.
It could be all of it. It depends on how the rules land. So it could be institutions, hospitals, long-term care facilities, and it could include individuals, should the rules include them.
Okay, very good.
Yeah. And that will help with the safety piece perhaps.
Hi, thank you. You may have already answered this question, and I apologize. I thought we did this already. Did we do a bill? Did it not work? Did it not pass?
Let me answer that.
Yeah,
Jen Carvey, Legislative Council. You've asked a couple of times that the health department look into this.
Oh,
So they came back to you with
We got the
sort of an
report.
update to updated report based on the letter you sent them last year.
Okay.
And they came back recommending that this move forward. And so the bill is implementing that.
okay, thank you.
yeah, so back in 2018, when we looked at Iowa, the expense was enormous to establish the program that they have. And it became a difficult decision, and then the pandemic came along. So we looked for an update, now we have the update, and now we have the department looking at how we might move forward, so. Good. Go ahead.
This seems like a great program. I'm really excited about it. My only question is, and I seem to be asking this question a lot, is there a sense that we have the capacity to put this in place right now, given how everything seems so stretched in terms of resources and staffing?
And I don't know that answer. I think the Department of Health is going to be the one to answer that question. But those things they're doing disposing of this anyway. And so this is just an alternative process for disposal locally, for our own institutions. So I don't know that it would make a huge difference, but I don't know enough of the detail how it
From
works.
Scooby Doo. With what dude?
Wow.
Somebody did something to make my phone talk.
Oh, boy.
Serious.
Oh, that's
I probably did it.
It already
didn't know it.
dings and now it's talking too.
Right.
We got dings in.
Okay. Any other questions for Representative Goldberg?
Just
Go
very
ahead.
quickly, so your comment, Madam Chair, about cost being enormous versus.
For the Iowa program,
Right, but I mean, it's all relative.
yes.
So enormous to Vermont is still. Anyway, my point is, your comment was that no cost yet, because this is essentially we're studying, we're developing rules, et cetera. So in the end, we're not really we wouldn't be committing any funds at this point. We're simply continuing to study. Okay.
Yeah, that's great. The recommendation for the Vermont Department of Health is they do their rules, they do their study, and then they come back to us through the VAA to get funded.
Okay. Thank you.
Any other questions? We're good. Thank you.
Thank you. This is
Thank
fun.
you.
It is, it does feel good.
Good.
We always like phone in here. Much as possible. Good. So you are from the Department of Health. Did you want to make a comment before we turn to Ledge Council or?
No, I'm happy to answer any of these questions. I can probably provide a little bit more detail. I was the author of this report. And I provided testimony in the House as well. So I'm happy to do that, but I also understand that I may be invited next week to
Yes, you
provide
are.
testimony as well. So
Okay.
whatever works best for the committee.
I think we'll go through the bill first. And
That's
then
great.
we'll see what we got.
Hello again.
Yeah.
Jack Harvey, Legislative Council. So I will, you want me to put the language
Yes,
up on
I
the
think
screen?
so,
No,
yeah.
I'm
Please.
prepared to do that. All right. We are looking at H414, an act relating to establishing an unused drug repository for Vermont. And so, as I mentioned, you had directed by a letter last year, this committee asked the health department to kind of look into, again, the idea of setting up or joining an unused drug repository program and report back. And they did provide that report, which is on the legislature's website, and you can get it posted to yours if that's helpful. And so this would add a new subchapter in Title 18, Chapter 91, which is our prescription drug cost containment chapter, on an unused drug repository program. It starts out by directing the Agency of Human Services or allowing them to contract or enter into agreements with qualified entities as needed to create and administer an unused drug repository program for the collection and distribution of unused drugs in Vermont. And then there's language here saying, to the extent that funds are appropriated or otherwise made available for this purpose. So it doesn't obligate any participation or any funding unless and until funds are appropriated or otherwise made available. Then it directs the Agency of Human Services to adopt rules for administration of the program, including rules regarding first donations to the program, which may include donations from institutional settings in Vermont, such as pharmacies, long-term care facilities, Veterans Administration facilities, correctional facilities, hospitals, and other facilities, as well as donations from individuals. So rules on donations to the program, what types of drugs may be donated to the program, safety criteria for donated drugs, which may include packaging requirements and inspections, patient eligibility to receive drugs from the program, which shall be available to any patient with priority given to patients who meet one or more of the following criteria. First, patients whose household income is below 400% of the federal poverty level, patients who are uninsured or underinsured, patients who are Medicare beneficiaries and are experiencing a coverage gap in their Medicare prescription drug coverage. This is the donut hole. And patients who are on a high deductible health plan or on a plan with high co-payment requirements for prescription drugs, or both. So everybody would be eligible, but there would be priority to people who might be experiencing particular financial pressures. Then there are some limitations on liability. So except in cases of bad faith, gross negligence, intentional misconduct, or non-compliance with the agency's rules, the following persons would not be subject to civil or criminal liability or professional disciplinary action for participating in or otherwise complying with the program established by this subchapter or the rules that are adopted. So this gives immunity to a person who donates or gives drugs to an eligible recipient, including a drug manufacturer, wholesaler, reverse distributor pharmacy, third-party logistics provider, governmental entity, hospital or other healthcare facility, as defined in this case, we're using the CON statutes, or a long-term care facility licensed under their licensure statutes. So immunity for them for an eligible recipient, as defined in the agency rules, a healthcare provider who prescribes or dispenses a donated drug, an intermediary that helps administer the program by facilitating the donation or transfer of drugs to eligible recipients, a manufacturer or repackager of a donated drug, and any employee, volunteer, trainee, or other staff of any person listed in those subdivisions. So basically, keeping the liability with the drug repository program and not with other people who may be involved in prescribing, dispensing, donating drugs. Section 2 would have an update required on the status of rulemaking for the administration of the program as part of the Agency of Human Services FY24 budget adjustment presentation. So that may include their request for funding if they're at that point, or that may take place as part of the FY25 budget process, but the expectation would be they would come back in the next year's session with rules and a request for funding, which you'll hear more about from Brendan. And the act would take effect on July 1st.
Okay, so in the development of the bill, how much does this model after somewhat perhaps Iowa or others have in place?
I think we looked at Georgia was one of the main ones that we looked at,
Okay.
which has a fairly robust program. I think Iowa and Georgia are the two main programs.
Yeah.
So that's where, for example, I think most of the limitation on liability language comes from.
Questions for Jen?
Just curious if paragraph 4, right where you are right now, paragraph 4 at the top, is the intent of ABC, et cetera, to be kind of a priority order?
Not in any particular order. Priority is for patients who meet one or more of those, but it's not in priority order. That's just, this group would have priority, potentially
You like-
priority
you-
over other
you-
Vermonters.
Okay.
Since the reporter of the
Okay.
bill is here, I just
Yeah, go ahead.
curiosity question. We'll get into this more later, but B and C, patients who are uninsured or underinsured, is often it's a personal choice. It's kind of a financial choice. I have a brother who decided, my second oldest brother decided not to be insured because he's taking that risk of, okay. I'm just curious. My impression is this would be for those who are not solvent enough to be able to afford insurance. But that would be covered under A, which is under 400% of federal poverty index. I'm just kind of curious why B and C are in there about uninsured and underinsured. Again, being that sometimes it's just a financial choice.
I think that you make a good point. I think when I think about it, I think the priority is for the drugs to be distributed. So let's say there was a drug and the best match was an underinsured, then that would be great, or, that kind of thing. So I think we just want them to get out. And we didn't really discuss in depth other than these are the people who should get them.
Okay. It's very,
This
Senator Williams.
funny,
Senator
I had the same issue, but who, and it probably will get answered in the rulemaking, but who determines who's, underinsured?
I think that would be a definition that would be developed in the rulemaking process. There are lots of different definitions for underinsured, but I would expect that would be something that would need to be spelled out more in the rules than what we're putting in that directive.
I don't know if you want to get into discussion at this point, but I think the majority of people who are uninsured are not uninsured by choice. They're uninsured by circumstance. And I was actually just going to suggest that we hear from this guy on this.
good coordination.
You're bringing?
He must have been listening to us. And that there's a significant number of Vermonters who are underinsured, who just can't afford health insurance plans that provide coverage, particularly for medications. So I think that especially if people require an expensive medication, they may not have coverage for it and could really benefit from a program like this. And many years ago, when I ran one of the free clinics in the state, we actually had a deposit. We got free samples basically, and that was, I'm not sure if that's still legal, but it was then.
Oh,
We
yeah, no,
got
it's
free
still-
samples from drug companies and used, provided them to patients. They were prescribed by a physician. We didn't just hand them out, but they were prescribed, and it was incredibly helpful for people who couldn't afford even basic medications. So I think this would go a long way, and I think your brother is definitely in the minority of people who are uninsured by choice.
So, but even people who are underinsured, and they may have insurance regardless of age or distribution. And if they confront the cost of a drug that is enormous, there may be access to that very costly drug for cancer or neurodevelopmental disorder, whatever it is. So, yeah. And we'll add you in, Mike, to this bill for the next time we take testimony. We're gonna hear from DOH. It would be good to hear your thoughts as well on this. Good. Yeah. Okay, any other questions for Jen? You don't know which bill we're talking about. We are talking about H414.
You just.
That was a heads up, Ray.
So you weren't listening.
Just heard uninsured and underinsured.
So, just clarifying what all those priorities mean. So if you haven't had experience with some of these terms and some of this, you do have questions, and it's good we'll get some testimony on it. Did you want to add anything?
No, I think, just thank you. Thank you.
All right.
Grateful that you're taking it up. And I just like the idea that we're gonna reach many Vermonters, than we know of, and that's great.
Yeah. And Department of Health will come in next week. Do you want to make any comment at this point for the record?
You know, the time we put Brendan at with Department of Health, I'm happy to answer all those questions. I don't know if, I've got the time to go through them all right now, but if any of them stand out, I'm happy to do that.
Well, you've heard the conversation and so what the questions are.
Yeah.
And so it will be helpful for you to come in next week, and I think we have it on next week. We do, and we'll have you give full testimony.
I look forward to it.
Yeah, great. Okay, good. All right. We're good. So, what I'm going to suggest is a 5-minute offline break to walk.